everyone, and welcome to a special episode of SCN8A Unraveled for International SCN8A Awareness Day. I'm Sarah Tay with the International SCN8A Alliance, and today I'll be interviewing Dr. Katrine Johannesen from the Danish Epilepsy Center in the Department of Clinical Genetics. Katrine, would you like to introduce yourself?
Yes, hi Sarah, and hi everybody. Thank you for inviting me. I'm excited to be here to talk to you today. Yes, my name is Katrine Johannesen. I'm a medical doctor and a PhD in epilepsy genetics. And currently I work in Copenhagen at the Department of Clinical Genetics, but for a long time I used to work at the Danish Epilepsy Center, where I did a lot of research, including SCN8A.
Well, I am so happy to talk to you today to discuss your work on SCN8A genotypes and phenotypes and how they relate to each other. Before we begin, is there any important background information we should know?
Yes, so I would like to just clarify maybe some general terms that we're probably going to use today. So when I talk about genotype, I'm referring to somebody's genes. Thus, in the case of SCN8A, when we talk about genotype, we talk about what kind of mutation an individual has, and also for this project, whether the variant causes loss of function or gain of function of the sodium channel. And we will get back to this. On the other hand, a person's phenotype is the clinical features that we see or can measure, and this will, for this project, mainly be seizure types, age of seizure onset, intellectual disability, or other features such as autism or maybe movement disorders and things like that. Also, I want us to have a common ground to talk from. So depicted here is a neuron, a brain cell with all its assets. And the green arrow indicates where the SCN8A sodium channels are located. And this is called the axon initial segment, or the AIS, and it's where action potentials are generated. So action potentials are these electrical signals that allows neurons to communicate with each other, so that when the action potential travels all the way to the nerve terminals, neurotransmitters are then released and bind to receptors on the receiving neuron, and that's how neurons communicate. So the sodium channels at the AIS are crucial for controlling how many or how fast action potentials are sent down the nerve axon. And to transmit these electrical signals, the channel must open and let sodium ions through the channel. And as sodium is a positively charged ion, then when the ions travel through the channel, there's a change in the charge, which allows the action potential to then travel down the neuron. So in the normal, healthy state, the so-called wild type, a sodium channel is finely regulated and only opens when specific conditions are present. So if, however, there is a change in the code of the channel, the gene, changes will also appear in the channel. This may cause the channel to open more slowly or be in an inactivated state for longer. That is what we call loss of function. Other genetic changes might cause the channel to open more readily or to stay open for longer, and this is what we call gain of function. These two options are equally damaging to the function of the channel, but as you will see later, they have very different ways of presenting themselves in humans, thus they have different phenotypes. And then what you see here is the process of functional studies. So determining whether a variant causes gain or loss of function of a channel is a very tedious process that requires actually hours in the lab. And thus it's not currently something that is readily available for patients, but it's only done for research purposes.
Well, thank you for that introduction. So now that we understand some of the details of SCN8A and why it's hard to get a gain or loss of function mutation, what was your recent study about and how did you come up with the idea? I guess I don't need the how did you come up with the idea. What was the recent study about?
So in our study, we focused on these two terms, gain of function and loss of function. And we wanted to know if it would be possible to distinguish between gain of function and loss of function clinically in affected individuals. And we think that this will be important for several reasons, and also because functional testing is, as I said, not readily available. So the reason for it being important is that currently there are anti-seizure medications that are able to limit the sodium channel. These are called sodium channel blockers. They are not directly aimed at the SCN8A channel, but still they might have an effect in some patients. However, it makes sense that only those with a gain of function should be treated with a blocker. Also, as you might know, the SCN8A community is looking into clinical trials with newly developed drugs that are specific for SCN8A, and these are mainly aimed at gain of function variants. Again, it will be crucial to choose the right patients for the right drugs. And we think that clinical markers will be helpful in making a qualified guess as to whether a variant causes gain or loss of function of the channel. And these clinical markers could include things such as age of onset or specific seizure types or specific EEG patterns.
That is so fascinating. So, how did the study work exactly?
So we wanted to include as many patients as possible. So I searched all the available literature to find any patients that had already been published. And at the same time, we reached out to our collaborators around the world to try to include even more individuals. I want to mention that I did my best to avoid double publication, thus not publishing the same individual twice as to not mess up the numbers. And in total, we were able to include 392 individuals, of which 91 were unpublished. And what we did was that we collected clinical data, and whenever a variant had been functionally tested, we also noted if it was a gain or a loss of function. So looking at the phenotypes of all these individuals, we then tried to make categories that could be used in a clinical setting. And we mainly focused on seizure type and degree of cognitive impairment, as these are measures that are easy to evaluate. And the categories were created on the basis of our current knowledge of SCN8A. Thus, we already know that a lot of individuals have focal seizures and focal discharges on the EEG, meaning that they have electrical discharges that are located to a specific or maybe several specific areas of the brain. So these were classified as focal epilepsies. On the other hand, we also see individuals that have generalized seizures, such as absence seizures or EEG patterns that are widespread across the whole brain. These were classified as generalized epilepsy. And then again, there were individuals that had both focal and generalized epilepsy, and that we couldn't classify, so these were unclassifiable. And there were also a lot of patients where we simply didn't have enough data or information to classify them into focal or generalized epilepsy. And then for the focal epilepsies, we then try to separate them into different categories depending on the degree of intellectual disability. And I want to apologize for using the term normal. This was mainly created for research. So today we will call it typical cognition. So these individuals with typical cognition are often part of large families that have infantile seizures, but eventually become seizure-free and do not have intellectual disability. So this is what we call benign familial infantile epilepsy or self-limiting epilepsy. And then for the individuals that do have cognitive impairment, we also use treatment response to distinguish between an intermediate epilepsy and then developmental and epileptic encephalopathy. I do want to stress that these categories are not to be seen as strict boxes, but rather a spectrum, as we all know that humans cannot be put into boxes.
Okay, I see. So basically, you found all these patients and broke them up into these loose categories based on their seizure type, what you saw on the EEGs, their cognitive skills, and then their epilepsy syndromes. And then based off of what you saw, then you could make an educated guess as to whether they had a loss or gain of function mutation.
Exactly.
That is incredible. So, what did you find with all of this?
Yeah, so for the results, we had a total cohort in Pi A of 392 individuals, and functional data was unfortunately, of course, not available for every individual or every variant. So we had a group that we know were loss of function variants of 34 individuals, and then for the gain of function variants, we had 136 individuals. So looking at the total cohort in A, we see that DEE is the dominating category, and we know that a lot of individuals have this phenotype. However, I want to mention that this might be biased, as I come from an epilepsy center and we have a large network of other epilepsy centers. And also genetic testing is much more common in individuals with epilepsy compared to those with intellectual disability or autism that do not have epilepsy. So we do expect the numbers of these latter categories to increase over time. And again, the gray slice are those individuals that either had both focal and generalized seizure types, or where we simply didn't have enough data to classify them into any of the other categories. And then in the next pi, we see in pi B, we see the cohort that have a loss of function only. And this differs from the total cohort, especially with a large proportion of generalized epilepsy, and also a large proportion of individuals that have a neurodevelopmental disorder but do not have epilepsy. In fact, only 2 patients in this cohort had a DEE. And then the third pi in C is the cohort that has gain of function only. And here we see that this group is solely made up of individuals that have focal epilepsies, and the majority have a DEE phenotype. So from this, we see that the phenotypes of the total cohort differed from that of loss of function, which again differed from that of gain of function. And this made us decide to look a little bit further into this to see if there were any more specific clinical markers that could be used to separate gain of function from loss of function. So taking a closer look, this a little bit busy table lists some of the phenotypic features from the different subgroups. So on the left, you have categories from the flowchart. The focal epilepsies are the 3 first categories, and then the generalized epilepsy is the 4th. And then on the right, we have the functional consequences, loss of function, and gain of function. And what we mainly noticed here was that there were similarities between the focal epilepsies and gain of function compared to generalized epilepsy and loss of function. For instance, age of onset. For the focal epilepsies, the onset is very early in life. And similarly, for the gain of function, it's also very early in life. While for the generalized epilepsy, onset was much later in childhood, almost 4 years of age. And for the loss of group, onset was around 2 years of age. So much later than the focal and the gain of function group. And we found the same things when looking at other things, such as cognition and comorbidities. For instance, central vision impairment and ataxia are things that are common found in DEE and also in the gain of function cohort, while language delay and behavioral issues are seen in the generalized epilepsy cohort and also in the loss of function cohort. So this suggests that age of onset, as well as cognition and other phenotypic features, could serve as clinical markers for functional outcome. We also looked at specific seizure types from the different cohorts. So on the left, we have the phenotypic categories with the focal epilepsies in red and the generalized epilepsy in blue. And on the right, we have the gain of function in red and the loss of function in blue. And again, we saw that there were similarities between focal epilepsy and gain of function, such as a very high prevalence of focal seizures and also tonic seizures. And we saw similarities between generalized seizures, between generalized epilepsy and loss of function, where absent seizures was the most prevalent. So this indicates that seizure type might also be a clinical marker for functional outcome. And finally, we looked at treatment response. Again, we have phenotypic categories on top and gain of function and loss of function on the bottom. And we see that the focal epilepsies resemble gain of function with a good response to sodium channel blockers, such as oxcarbazepine, carbamazepine, and lamotrigine. And this makes sense, as we would expect that gain of function responds to sodium channel blockers. And on the other side, we see that the generalized epilepsies and the loss of function variants have none or maybe even a poor response to sodium channel blockers. But instead, we see a positive response in both generalized epilepsy and loss of function to valproate. And what we used this treatment information to was to add it to the final flowchart that I will show you in a bit.
Wow, that is a lot of information, but how are these results going to be used clinically?
Yes, so all in all, we found that clinical markers such as age of epilepsy onset and type of epilepsy that we already used to make the initial categories were also good markers for the functional effect of genetic variants. And ultimately, we also decided to add treatment recommendations to the flowchart. So those categories that are focal epilepsies are most likely gain of function and would probably benefit from sodium channel blockers, whereas generalized epilepsy is most likely loss of function and will not benefit from sodium channel blockers. And we hope that this may be helpful in a clinical setting where you have a mutation where you don't know the functional effect and functional data is not readily available, and you have to use these clinical markers to guide your treatment strategy. And with that, I just want to say thank you for inviting me and listening to me. And I hope that perhaps some of you or your doctors will be able to join us for the epilepsy conference in April.
Well, thank you so much for your time, Katrine. Your work is so promising as it offers more insight as to how a visit with your doctor can give some indication to whether your child has a loss or gain of function, mutation, and how they may progress and be treated. To the rest of you, thank you for joining us for SCN8A Unraveled, where we unravel the science of SCN8A. We will link Katrine's paper below, and as always, we look to you to choose what we cover next. Let us know what your biggest SCN8A related questions are in the link below.